الله الرحمن الرحيم. ان شاء الله نبتدي السيشن دي، والحقيقه احنا سعداء جدا بحضوركم المؤتمر، سعداء بالمؤتمر وبتنظيمه وبالناس اللي شرفونا، ويشرفنا ان احنا يكون اول محاضر لينا في السيشن دي الاستاذ الدكتور خالد مكين، استاذ جراحه التجميل في القصر العيني ووكيل الكليه لشؤون البيئه. الدكتور خالد مكين هيتكرم ويكلمنا النهارده المحاضره بتاعته على plastic reconstruction in cases of vaginal atresia.
بسم الله الرحمن الرحيم. أحب أشكر اسم أمراض نسا على دعوتي. دي أول مرة يعني أتشرف إن أنا أكون في المؤتمر الناجح لاسم أمراض نسا. هتكلم معاه النهارده على موضوع أنا يشغلني من أكتر من 25 سنة، وهو جالي بالصدفة. أنا كنت نايب الله يرحمه الدكتور حسين طلعت في اسم 11، وحضراتكم عارفين اسم 11 يتبع مستشفى النساء، فأنا جغرافيا وعائليا وتاريخيا أتبع مستشفى النساء قبل ما أتبع اسم جراحة التجميل يعني. وكان في الفترة منتصف الثمانينات كان في انترست كتير قوي على الموضوع اللي هنتكلم فيه، وهو الفاجينال اتريزيا، ودخلنا منه الموضوع تاني وهو الانترسكس. يمكن لأسباب قانونية موضوع الانترسكس في مصر ابتدى ياخد، او الترانسكس بمعنى اصح، ابتدى ياخد منحى مش منتشر، وكنا بنشتغل منه كتير اللي هو الترانسكس بالذات. لغايه دلوقتي ما بقى فيه ريجوليشنز في نقابه الاطباء لحالات التشينجينج ذا جندر يعني. موضوع الفاجينال اتريزيا هو للاسف الشديد مش واخد حقه في مصر كما يجب يعني أنا in the last 25 years I passed through different techniques. وعلى فكرة مش واخد حقه حتى في أمراض نسا، وحتى في جراحة التجميل أو في اليورولوجي اللي هي الحاجات، جراحة الأطفال ساعات الحاجات اللي لها علاقة بالموضوع. لأن الفاجينال اتريزيا is not rare. يعني زي ما هنشوف دلوقتي إن أغلب العالم بيقول إنها في 1 ل100,000 فيميل عايشة. And this is a large number of cases. Was strange enough, when I start to work on this vaginal atresia, I found it can be diagnosed very late. Even the patient get married and she had no vagina. And after few months of marriage, and sometimes I have patients intercoursing through the urethra with cystitis, and they have no any vagina, whether closed or not existing. Atresia can be absent vagina completely, or closed vagina. It can be an hypoplasia, or fortunately if you have imperforate hymen or transverse vaginal septum. In the literature, transverse vaginal septum is said to be extremely rare, but I have in my career 5 or 6 cases of this transverse septum, and excision of this transverse septum completely without any remnants to avoid recurrence. I think they have a very good results. Or as you all know, imperforate hymen, these are minor forms of vaginal obstruction. It is not an atresia. And I saw some cases of labial adhesions. I don't know what is your experience in these acquired labial adhesions. They are normal females with adhesions with the labia minora. Labia majora is okay. And I start to use surgery to separate these adhesions in the childhood, but I found in your literature using ointments with estrogen can solve this problem, but I did not use this till now, and I need to share your experience if you have any patients with this labial adhesions. One of the things which are very important in Egypt and we are lacking totally is the so-called newborn examination. I used to work in conjunction with vaginal atresia about brachial plexus injuries, neonatal brachial plexus injuries, herpes, and etc. paralysis. And newborn examination, it is not in Qasr al-Aini or in other big hospital now, but in the countryside, they did not examine patients. The birth injuries are neglected, so also the genital examination is neglected. So this is why we have these patients with vaginal atresia diagnosed very late, diagnosed, as we say, by a primary amenorrhea or hematocolpus, or as I told you before, after marriage even. What is more dangerous than this, that vaginal atresia can be associated with many syndromatic anomalies. And I go back to the literature, I have more than 30 syndromes. It can be a major question in the MD exam if you have these syndromes with vaginal atresia, with the urinary problems, with anorectal problems. And I found these are MKM, Rotanesky, Meyer, Kuster, Hanser syndrome. It is, in the Western countries, it is one of the famous syndromes. It has heart lesion, it has syndactyly, it has some urethral problems, but isolated, this is what is more important, isolated vaginal atresia with a normal uterus, it is extremely rare. Isolated vaginal atresia with an absent cervix, it is extremely rare to find a functioning uterus, absent cervix, and atresia. I have only one patient I operated upon with Professor Ahmed Abu Nasr. It is a female from Yemen. Was an extremely difficult case because we don't have cervix and we have uterus functioning, we don't have vagina. As I told you later, I used to do for these cases vaginal pouch first, sometimes transferring part of the sigmoid colon instead of the cervix, but unfortunately in my limited experience, and I think in Egypt, some of my colleagues in the gynecology and general surgery department, Dr. Ihab Suleiman, Dr. Ahmed Farag, Dr. Antoine, they used to do this surgery, but I think this is a failed surgery. And I may recommend for these rare anomalies with isolated vaginal atresia with absent cervix to do hysterectomy very early. But what is more common, and I saw it several times in my life, which is Mullerian agenesis types. We have different types of agenesis of Mullerian duct system. One of these agenesis is total absent everything. We don't have uterus, we don't have cervix, and we don't have vagina. And in these cases, as I told you, it is one for 10,000 live females. These patients are suffering from primary amenorrhea, or they may get married and they have sexual problems. But all these kinds of anomalies must be diagnosed in the newborn examination. And in Egypt, you have to encourage the neonatologist and maybe the gynecologist. You have now a big branch about fetal surgery, fetal diagnosis intrauterine. We have 3 and 4D sonar, and these ultrasonography, I think, can even help in the diagnosis of these cases intrauterine. And by examination, we can get, I don't mean that you have to treat these patients very early. No, we are not treating these patients except with anomalies in the urinary system or the anal canal, like imperforate anus, like the RM syndrome. But you have to diagnose these cases immediately after delivery. If you pass to the history of treatment of this vaginal atresia, in 1930, it is Baldwin in the United States start to do intestinal grafts. And the first surgery to be done, it was not using skin graft, but it is using of intestinal graft. It is not flaps. He used to take part of the colon, separate it totally from its blood supply, get it down to create the pouch between the urethra and the anal canal, and put this graft as a conduit or as a new vagina. And after 10 to 15 years, Makendo and his colleagues start to do their famous surgery using a skin graft over a conduit, over a mold, and get this pouch through an H or Z incision between the rectum and anal canal, and rectum and anal canal and the urethra, to create this blind pouch using this mold, and this pouch will be lined by a split thickness graft from the inner thigh. This operation now, it is from mostly about 18 years now, 80 years or so, more than 85 years. And we are going to review some modalities of treatment. But like the old movies called Back to Future, now today, I say Mackendo's operation, which used to be done in the last more than 80 years, stands, as I tell you now, the test of time. It is the simplest and easy with very minor complications. But we can go to non-surgical treatment of some cases, only some cases of vaginal atresia, like regular dilatation. This is very important. Sometimes you have a small pouch, small dimple. If you have this dimple, don't rush to surgery. This is another very important point. You can do this regular dilatation. This regular dilatation, use dilators, it's very useful. Sometimes we don't have anything. And as I said before, in transverse septum, full excision of the septum without remnants is mandatory. But when we start treatment in the late teens for many reasons, psychological or anatomical reasons, but we don't operate with these patients early in life, whether use dilatation or frank surgery. Sometimes you have to get medical therapy to stop the menstruation if you have a closed uterus, but this is, like I told you, is very rare. Our aim in vaginal atresia is to restore normal sexual life without pain. This slide shows the summarization of the different techniques. We can use, as I said, extra abdominal tissues. This is Abe Mackendo's operation, which, like I told you, stands the test of time. Using this classic operation, still after I went to far away for treatment of different modalities of lining this pouch, Mackendo's operation still easy, least amount of complications, and these complications like restenosis or fistula formation, it is very rare with Mackendo if you do the surgery good. And what the tips of surgery of Mackendo is to create a good pouch, so an H or Z incision between the urethra and the anal and the rectum. Take care the rectum is very closed, and you cannot easily injure the urethra in these cases, but can very easily go to the anal canal. So we must be very cautious about this. Be sure of you creating the pouch by sharp and blunt dissection that you don't injure the anal canal. This is number one. Number two, you take a split thickness graft from the inner thigh or outer thigh, a medium-sized skin graft, to put it inside this pouch, and you get a mold to be changed under anesthesia after a week, and must be under anesthesia, regular dilatation, and if the patient is not married. But if the patient is married, you can starting intercourse after 1 month maximum. This will help to avoid restenosis. What is the most dangerous things in Mackendo's? That lack of sensation, of sexual sensation during the intercourse, lack of lubrication. But the first problem of Mackendo, I have patients operated upon more than 25 years, they can acquire this sensation. Yes, the flaps, the grafts, I mean the split thickness graft, can acquire sensor, but if have a regular sexual life, I don't think that's a problem, and they can use artificial lubricants. What is written in the extra abdominal tissues here, I think I tried all these, and all of them are failure. Like using the mycutaneous flaps, rectus or Garces are very bulky. They have a very good shape, but they do not have the function of the vagina. Get a bulky vagina, which is not normal. Actually, the epithelium of the vagina, which is normal vagina, is the same epithelium of the skin, so it's much better. Fasciocutaneous flaps are failure also. Using tissue expanders, it is only in limited cases of low atresia you can expand the vulva. You can expand the labia majora. But I think this is also difficult because actually you still have the skin graft is a better solution. In Germany, I found, I did not have experience with this, but they have some experience with some biomaterials. This is to avoid using the skin graft so as not to get scars. But I told them that if you have a skin graft taken properly, this after 1 month, you don't have any scars. So I think it's not. Abdominal tissues, instead of the vagina, I think you can do an ultra-major surgery for less minor procedure. I think abdominal surgery is only for cervical substitution, and also they have very bad results. But also for vagina, taking the sigmoid colon not as a graft like the American used in the 30s, no, as a flap with its blood supply. The quality of the skin of the colon or the intestine, it is not that quality of the vagina, so I don't have any superiority of this kind of surgery above the Makendo, which is the classic old one. In the United States, they use the laparoscopic assisted or open. This is not important, but laparoscopic Vichetti using an acrylic olive, this is an interesting surgery. I have only one patient, but I don't have now the results because I used it about a month ago. I saw this operation in the United States and in Germany. They have an acrylic olive to be put in the pouch or dimple of the vagina, and this acrylic olive will be connected to an apparatus inside the abdomen, and outside the abdomen is some complicated case to expand or do some traction on this pouch. I think it can solve more natural problem, but I told you the simplest Makendo procedure still stand the test of time, and this is my recommendation for even junior or senior staff in the gynecology department. Using this old technique is still good. This is a case of complete atresia before surgery, and this is the shape after surgery. But sorry enough, I don't have the in-between surgery because I close all the labia majora over the mold. This is the patient. This is the last patient I operated upon about 15 years ago with transsex. And I have a message to be for you or for the medical syndicate about these miserable patients of transsex. This is a psychological disorder from childhood. He is a male, phenotype and genotype 100% male or a female, but psychologically speaking, he is totally different. And many of these cases are operated upon early, are diagnosed early in life, and with the psychiatrist, they can change the gender. But if you don't have this change of the gender, you must follow the patient's psychological status to be transformed from female. This male was a small penis and these testes. Here I'm using, I'm opening the pouch, removing the testes, but here I don't have to use a skin graft. Here I'm using the skin of the scrotum as a pedicle deflap to line the pouch. And it is very difficult cases of these transsex, not the vaginal atresia, because you don't have a space. In the vagina, even atresia, you have a good space between the anal canal and the urethra, but in males, you don't have this space, so it is difficult. And in Asr Al Aini now, we are doing these cases after permission from the medical syndicate and the Ministry of Health. Thank you.
Thank you, Professor Makeen, for this interesting presentation. Intersex and transsex. So, do you have cases of transsex, as I understood?
Yes.
That psychologically they want to be females.
Yes.
Intersex born with ambiguous genitalia,
Yes.
that you change according to the genotype.
Yes, ambiguous genitalia is not a problem because it is can easily diagnosed and you have different changes of this. But transsex is a psychological disease. It is found in Egypt. They are not homosexuals. But the regulations here in Egypt is difficult for these patients, like because they have a complete male pattern, but from the very early in life he is a female. And about 10% of these cases will commit suicide by amputating their penis if you don't interfere psychiatry from the first day of life, and if the psychiatrists fail, it must be transferred to a female. And the transfer is not only genital transfer, but you have the breast, the face, the mandible. We are doing many things in plastic surgery about these miserable patients. And we use a lot of these cases. And actually in Egypt, the late Professor Gamal Bihari, who was the first man in the 50s on earth doing this transsex. But now I think after the new era of understanding of medicine, this will be more clarified among the population that transsex are not homosexuals. They are psychologically disturbed. They must be treated very early in life, diagnosed very early in life. But ambiguous genitalia is difficult. But we have some cases of gender problems, like I have different patients with undescended testes in the abdomen, very small penis, rudimentary penis, bifid scrotum, perineal hypospadias. These are misdiagnosed. They are normal males with this ambiguous genitalia. They are diagnosed as a female, and they are reared as a female. And after they get primary amenorrhea, you go to the gynecologist, they are males. And they have beard, they have mustache, they have everything. But the problem now, what to do for these patients? She is a male with XY chromosomes, but we have, and even the testis can functioning for the testosterone, so it is normal male with some problems, undescended testis, perineal hypospadias, small penis, diagnosed as enlarged clitoris. If you tell the parents she will be transferred to a male, they cannot accept. So I think you have to obey the patients and the parents' wish. This is a major problem, not in Egypt, even abroad, if you can transfer this to a male or to keep it as a female.
What about Dr. Ralph's experience in this case?
Well, actually, this isn't working. I'll try to talk out louder a little bit. Thank you. Our experience from our hospital is that we had treated in the last 4 or 5 years 11 patients with Myrick-Katansky-Kuster-Hauser syndrome, and we apply the Vicchetti laparoscopic procedure. And as the colleague said, it's a good procedure when you have a small pouch. It is sometimes enough to have 1 centimeter of a vaginal pouch, and then you can apply this kind of operation. And in most of the patients, we have a normal functioning vagina in about 7 to 8 months after the primary operation. You will have to change the phallus, the phantom you use for the vagina, each time you repeat the operation until the desired length and width of the vagina is created. My principal, the director of our clinic, has started with this operation in the University of Tübingen, where he had been before changing to our hospital in Hamburg, and he can look back at a number of, I think, 28 or 29 patients treated with Vicchetti. In some cases, when the Vicchetti operation isn't enough, we perform the intestinal pouch or conduit, and we do it in laparoscopic assisted vaginal manner, and we have good results too.
What about transsex?
In Germany, this is a little bit regulated through the ethical committees and through governmental issues, and is totally in the hands of urologic colleagues. So even urogynecologists aren't allowed to participate in this issue. So this is a total urologic issue. So we don't do it neither in our university hospital, nor do the other universities gynecologically do it.
I can ask you about the Vicchetti
Please.
technique. Do you have do you use in the laparoscopically, you do the suture above the pouch, you have the acrylic olive and the traction, but you don't have any sutures above the expected pouch?
Well, actually, you put the phantom.
Yes.
You put the phantom as the last step. The first step would be that you go laparoscopically.
The first step.
The first step, you look inside the small pelvis, and you have a second experienced colleague performing a cystoscopy, and he would be ready to perform a rectoscopy parallel too. So when you start, sometimes the perineal tissue, or what is meant to be a perineal tissue, is so scarce, is so rare, that you have only 1 or 2 millimeters between the bladder and the rectum, and these are the hardest cases to do. So you do, like you said, Z-form plastic vaginally, just to split the skin, and afterwards, while one colleague is looking laparoscopically and the other doing the cystoscopy, you go with a very small device in this area of tissue, split it again under laparoscopic control, place your threads, the threads are placed on the phantom, and the whole apparatus is then stretched subperitoneally until the leading edges of these wires are taken out transabdominally and attached to the stretching device. And the stretching device, one of the most common wrong things to do in this case would be to perform too much stretch on the tissue, because it would be less perforated and it would be less perfused, and healing would be worse. And
This
then
is why they use this Fascetti technique can end with restenosis several times.
you
I
are
don't have
absolutely
experience
right.
except in one case, and this is a very early case.
Yes.
But they told me that in Germany that it can be restenosed easy.
You
The
have-
stretching.
Yes, you are absolutely right. You have to teach your patient to use the phantom intermediately at home. And afterward, you replace the first phantom with a bigger one, not only longer, but also wider in size, and this is very important. Sometimes you can, when you have like 3 or 4 centimeters of vaginal tissue, you can perform a classical vaginal Z plastic on the posterior wall, stretch the tissue, apply a flap on it, and remain the same operation with a bigger phantom afterwards. So you got to be a little bit patient.
Okay, thank you, Ralph. Any questions for Professor Makin?
Thank you, Professor Makin, for excellent lecture about the vaginal reconstruction. I am Mohammed Khalaf, lecturer of obstetrics and gynecology in Asyut University. There is multiple publication and multiple operation we do by my professor Ali Samman, professor of obstetrics and gynecology in Asyut University, by using of balloon dilatation, by using a trocar made by Professor Ali Samman, وخد عليه براءة اختراع ان بيدخل عن طريق اللاباروسكوب through the in front of the umbilicus يوصل لحد الدمبل بتاع الفاجينا ويدخل معاه الفوليس كاستر بيبقى مربوطه فيه، بعد كده يعمل ديفليشن وبنركب امبلايكال، نعمل تراكشن ونركب امبلايكال ستامب امبلايكال كلامب every day using another umbilical clamp. Traction every day increase the vagina 1 centimeter per day. 8 days vagina increasing 8 centimeters, and there is a multiple publication about this. I ask you حضرتك عملت comparison study بين what you do and this is balloon, and another question, هل ممكن نستخدم using balloon in trans 6 or not? Thank you.
مش يا حبيبي، اولا هو البالون دايلاتيشن انا سمعت عنها بتاعت اسيوط، لكن هي موديفيكيشن اوف ذا اولد فاشيتي تكنيك اللي احنا كنا بنتكلم عليه دلوقتي، اللي هي يوزنج تراكشنز ان elongation اوف ذا فاجينا. بس انا للاسف ما عنديش خبره معاكم، او مع يعني انا ما قريتهاش يعني، فيا ريت.
حضرتك هي منشوره في الاستريت فيرتيليتي اند ستيريتي جورنال ميني بابليكيشن اباوت ذس يعني.
انا بتاع تجميل يا ابني، مش بتاع نساء، فاحب قوي اشوفها، بس هي نفس